Okay, so I don't know, I think I've at least met everyone, but I've been working with Therafit for about 3 years now. So I kind of have come a long way with maintenance therapy. So I understand it's a really hard topic because it doesn't follow any specific rules, any specific patterns. And so when I first came out of school, I thought, okay, what is maintenance therapy? I really didn't know too much about it, and I had very little understanding of it. And then when I started this job, I still had pretty little understanding of what maintenance therapy was and what it really had to offer for people. So when I came into the job, I was like, oh, these people have been here. I'm like, what could we possibly be doing for these people at this point? And I didn't realize how important maintenance therapy was until I had a patient who we discharged. Well, they had discharged kind of right before I had seen them, and I read their current level when they came back about 6 months later, and kind of what they came back to was so crazy. They had lost kind of every single thing that was in the note. They had lost even the ability to even hold their head up at that point. And that was without any medical changes, any drug changes. So that's whenever I really thought, what is maintenance therapy and how could we use it? So that was kind of like a changing point for me. Okay, so the objectives for today are to understand the history and importance of Medicare maintenance therapy, to learn the definition of skilled versus unskilled therapy, to determine what patients are appropriate for maintenance therapy, to understand the role of maintenance therapy in an outpatient setting, demonstrate confidence in how to document maintenance therapy, master your ability to successfully create a maintenance therapy program, understand the benefits and effectiveness of a maintenance plan, and be able to express the therapist's role in a maintenance therapy program. So I just kind of wanted to put this out there and kind of get everyone thinking. Does our fear of providing too much physical therapy exceed our concern for providing too little therapy? Often we're so focused on the end date and how much therapy we're providing. I don't know if a lot of us stop to think, are we providing too little therapy? Or did the doctor recommend too little therapy? So just a brief history. So basically a case was filed in 2011. The patient was a 76-year-old female. She was receiving home health. She had diabetes. She had a below-the-knee amputation on one side, and she was missing toes on the other side. And she was blind, and she was a mother of 4. So she was receiving home health to maintain her abilities to be a mother and do everything in the home. So they discharged her, saying that the rule of thumb, that she was plateauing, there was no improvements. And then at that time, she decided that that wasn't okay. She still needed the therapy to complete her roles and to complete her daily activities. So at that point, they filed a lawsuit. So then in 2012, the lawsuit was filed. And then there was a hearing later on in that same month. And then finally in 2013, the approval was granted. That is officially kind of when Medicare said, yes, maintenance therapy is a thing. So out of the settlement, these are kind of the big bullet points that came out. They were allowed to review denied claims, revise and clarify the benefits, provide a nationwide education campaign, and then randomly sample non-coverage decisions. The biggest thing that came out of this was they got rid of the improvement standard. So Medicare basically said that they really never had an improvement standard. It was just something that was always implied, and something that kind of once it was implied, everyone followed. So now what they are saying and clarifying is that there is no longer a situation where improvement is needed. You can still have the skilled care. So it doesn't depend on the person's potential to reach a certain point. It's if they still require the skilled care. So just some more clarification. So again, services. of a qualified PT or OT, not a PTA and not a CODA. Coverage does not depend on improvement potential, but rather on skilled need. Specialized skills, knowledge, and judgment of a qualified therapist to demonstrate effectiveness. So the ones in quotes are taken directly from Centers for Medicare Services. There's no rule of thumb, and services are necessary to maintain, prevent, or slow a patient's further decline or function. So the biggest takeaway is there's no rule of thumb, which as therapists we all hate because all of us are number-based and we're all yes or no and column-based. So yes, we continue. No, we don't continue. Where now it's more we have to use our brains. We have to think. There is no rule of thumb. So there is no checkbox that we can pick that says this person goes into therapy or this person doesn't go into therapy. The fundamental issue for coverage under the clarification is whether a patient needs professional services to maintain or prevent or to even slow the decline or deterioration. And also Medicare pointed out that this is not just for people with progressive neurological conditions. They're also pointing out at this point that it can be used for chronic conditions. And often now people are also using it prior to surgeries. So prior to limb amputation surgeries and even prior to joint replacement surgeries, because those people are requiring therapy even though they are going to eventually get a surgery to change, but you're trying to maintain them at their current strength level before they would have this surgery. And whereas before they might have hit their cap or they might not have been able to continue to get services as they wait for the surgery, now they're putting them in a maintenance plan. So who qualifies for maintenance therapy? So like I said, there's no specific diagnosis that qualify a patient for maintenance therapy. Medicare coverage is not limited to patients with progressive conditions, and the coverage decision cannot be based on just the diagnosis. The key issue, which you're going to keep hearing, is whether the skills of a therapist are needed to treat the illness or injury, or whether services can be carried out by a non-skilled person. So you need to consider the impairments and functional limitation of each person you're dealing with. For me, it's easier to understand Medicare maintenance therapy when you understand the ICF model, which we'll kind of review in a little bit. The ICF model allows you to understand the whole patient, so you need to look at not just the patient, but also their environment, their barriers, their roles and responsibilities. It's easy to consider progressive neurological patients to go into maintenance therapy because we know they're progressing. But like I said, you don't necessarily need to be progressing through a disease to be in a maintenance plan. It could be a point in your life where it's now a chronic condition. It could also be a point in your life where you're aging with a condition that you've had, which again is a transition. And then, like I said, they're also now using it for people who are waiting for surgeries. Okay, so the biggest thing, which we keep saying, is skilled versus unskilled. So what makes something skilled? What makes something unskilled? For me, I think what really hits home is the fact that we went to school as PTs for a very long time. Now that PT is a doctorate degree, why is it a doctorate degree? It's a doctorate degree because we now all fall under the skilled category. Before, whenever it was a bachelor's or a master's and a doctor or physician would give you an order and you would carry out their plan, that was more of an unskilled therapy. Now that we have a doctorate degree, we're all giving out skilled therapy. It's the same reason why a lot of OT programs are also switching to doctorate degrees, because we are now generally the first line of defense for most of these patients. Generally, they're coming to us first before they go to someone else, and they're asking, is there something that can be done? And they're looking for advice. We're also the people that are spending the most time with these patients. Oftentimes, they see their neurologist once, twice a month, twice a year. Maybe they've never seen a neurologist, and we're the first people actually seeing them and actually talking to them. Where a neurologist may spend 5 minutes with them and then send in their physician assistant to say, okay, you need a script for this, a script for that, that's fine. We are actually spending a full hour during our initial evals, even just getting to know them, understanding who's with them, understanding what makes up their lives. Also, we're generally the first people to notice a change in their behavior because we do spend so much time with them. So if you have a nonverbal patient and all of a sudden he starts doing a tic out of nowhere, that's when you start to wonder, okay, are we having increased seizures? Is there a change in status? And lastly, I would also say that since we do spend so much time with these people, we're also the ones that notice if they are becoming worse. So, now it is time for you to go to your neurologist and talk to your neurologist because all of a sudden, out of nowhere, your foot drop has gotten worse. So I would say we often are giving a voice to the voiceless, and we're definitely educating people about their diseases and also the newer things that are out there for their diseases. In general, all therapy we provide should be skilled. So it shouldn't really be a question of unskilled versus skilled, because if you look at the unskilled therapy, there would be no reason for you to be there. So really, when you look at skilled, it's more or less everything you do in a session that sometimes you don't even think that you're doing. So it's all those questions you're asking in your brain, like, oh, is that foot drop different today? Are they having more tone? Has their spasticity changed? All the things that you may or may not even think that you're doing, but you go through periodically in your brain, like, those are all the skilled comments. Or every single time you give a verbal cue to a patient, that is a skilled comment. Where someone who did not go to school, did not learn any of that, would not know to give that cue. So this is another important point. Can unskilled become skilled? So yes. So as taken from Centers for Medicare Service, a service that is ordinarily considered unskilled could be considered a skilled therapy. In cases where there's clear documentation that because of special medical complications, skilled rehab personnel are required to perform the service. So this topic right here also is really important for our setting, because due to most of our patients who have complex medical needs, often we see patients that have not 1, 2, or 3 diagnoses. They've often been through a lot. We also deal with a lot of patients that have either aging caregivers, so parents that are taking care of them, or in general, they're using a caregiver service where they're rifling through caregiver after caregiver after caregiver. So when you take into consideration that often these people do not have consistency or someone who is going to be able to do things consistently, this is again when skilled can become unskilled. It's also when you take into consideration all their diagnoses. So if they have high blood pressure, they have diabetes, they have a heart condition, and you know that they're on a laundry list of medication, and you're monitoring their vitals maybe here and there because you realize sometimes they're off, so you throw a blood pressure cuff on them. So this is again when skilled becomes unskilled. When unskilled becomes skilled because you're performing these heart rate checks, you're now performing blood pressure checks, you're reminding them after exercise, check your sugar, redo your blood sugar again, or you're reminding them, let's take our blood pressure after we exercise. So that's again kind of when unskilled can become skilled. And additionally, we often, like I said, deal with changing caregivers or elderly caregivers. So NIOSH, which works with OSHA, recommends that no one lifts, so this isn't an industrial worker, and this is in an ideal lifting situation, more than 51 pounds. So as I'm sure all of you know, none of our patients are an ideal lifting scenario. Most of them don't even bend in half. The rest of them don't have handles, and we're generally not moving them from one plane to another. We're often moving them from a wheelchair to another setting. So in that case, NIOSH lowers the weight whenever you're asked to do something repetitively or whenever you're asked to do it with twisting or with bending, which is often how we are asking people to do passive range of motion. We're often asking them to lift a limb, or we're asking them to bend down to meet the level of the limb and pick it up, or we're asking people to move themselves around the passive range of motion. And with that, you're not supposed to lift anything more than 8 to 12 pounds, and that too is in an industrial worker. So when you think about our caregivers or the people who are performing the home exercise program, you need to remember that you are also placing them at risk. So you need to realize that 8 to 12 pounds is what is being recommended, and that's again in an ideal situation. So the next point that we bring up is responsiveness, not improvement. So when we look at these patients, it's not whether they are progressing through our therapy. It's if they're responding to our therapy. So the language changes. So it's no longer patient is making good progress towards goals. It's the fact that are they responding to our therapy, what we are providing. So progress is not synonymous with improvement. Progress in a maintenance therapy would be responsiveness. So if they are responding, then they are making progress. A patient's capacity to function at an optimal level, we need to consider it within their stage of severity of the disease. So no longer can we say we're comparing it to normal, we're actually comparing it to their stage of life, their stage of their disease. So with us, pretty much everyone should be able to respond to our treatments because we are very patient-centered. So we involve the patient from the start. So we are only working towards things that the patients want to be working towards or want to maintain or want to keep. So there should be no reason why they wouldn't be responding to what we're doing. And if they aren't responding, that's more back on us as a therapist to change what we're doing. Or is there a new piece of equipment? Is there something different we can try with them? Is there another way we can approach it? Could we put them in a different position? Could we try a new technique? So with responsiveness, I would say, especially at my clinic, we're always trying to try new things with people to get them to respond to treatment. So maybe for a week, one type of treatment was working and it was always working. And then all of a sudden, they're not really into it anymore. So what changed? Not necessarily their medical condition, not necessarily anything with them, except for the fact that just like us, we become bored. We don't tend to go to the gym and stick on the same routine every single day for 6 years in a row. That is why we change what we're doing to help these patients become responsive to our treatment sessions. So I know at my clinic we're buying new toys all the time, and I even mean toys for adults. We have push button toys, so we do use our iPad a lot. We do a lot of different things to encourage people to try different things. So even just getting people to use switch button toys is another way of getting them to respond to the treatment or become more invested in the treatment. So goals of a maintenance therapy program are often any of these categories. So another big thing about maintenance therapy is it's generally considered a type of preventative care. And especially with the Affordable Care Act that changed a lot of things, it became this whole holistic approach to preventative care. So goals need to be patient-centered, which we already do, and they need to be tied to the environment the patient's in too. And maintenance goals are going to be different for every single person. And as long as the goals are matching what the patient wants to do, then they should be responding to them. And then again, I know often when we think of maintenance, we don't necessarily think of people who are super mobile, but your goals can also be mobility goals. They're allowed to be about walking. They're allowed to be about standing. Interestingly, too, they also are allowed to be about education. Even if you're educating the family on when certain instances occur. So you are allowed to have maintenance goals versus around educating family, educating caregivers. And you're also allowed to have them for reducing fatigue. So a lot of our MS patients, we use that as a pretty big maintenance goal, is the reducing fatigue. Transition into maintenance care. So often we don't start people in maintenance care. Not to say you can't, you are allowed to start people in maintenance care. So if you see someone and they've had PT somewhere else, or they're coming to you and you think that they should just start in a maintenance program, you are allowed to make that call. But what generally happens is we transition into maintenance care. So another important thing to realize is that not all disciplines need to take the same approach. So just because PT is doing maintenance to begin with, OT doesn't need to start at maintenance, and vice versa. If OT starts with rehab and then transitions to maintenance, then that's okay too. It requires that you coordinate with a doctor. So if you're transitioning someone from regular rehabilitative therapy into maintenance, you have to contact the doctor and make sure that they are agreeing with your plan of care to continue. And you're sending your eval, you're rewriting your goals, and then you'll send a letter of medical necessity, which is already loaded up in our share drive. So all you have to do is basically put in the patient's name, their limitations. So documentation is actually what makes maintenance therapy possible. Because it's documentation that allows us to demonstrate that it was skilled. Without the documentation, there's no way to prove that it's skilled. So a list of suggested goals, also language generally used is also on the share drive. And those are all really helpful when you're writing maintenance plans. Like I said before, it's easier to document using the ICF model. And tolerated well or without adverse reaction is not going to be enough for a maintenance plan. So again, maintenance plans depend on documentation, which shows that you are skilled enough to document and use your words that you learned. So the ICF model, are you guys familiar with this? Okay. I know that it's newer for schools to be teaching, but why I like the ICF model for maintenance documentation is because it's one of the few models that actually takes into consideration environmental factors and personal factors. And as we've seen also on WebPT, they've started to include that with the low, medium, and high, because now they're asking you and prompting you to pick, was it, their personal factors or barriers to therapy? Is it because there's multiple things? So WebPT is starting to prompt to look at a patient this way. So I'm kind of urging everybody to as well look at patients this way. Because it's these two in the bottom, the personal and environmental factors, that often are what make us transition people to maintenance therapy and not just discharge them. Is there a personal reason, why we can't just discharge them? Or is there an environmental reason why we can't just discharge them? As long as we consider the whole patient, it's a pretty easy way to transition them into maintenance. And then again, we have to also consider their pre-existing conditions. So I would say these three in the middle are what we're all used to documenting about, where the one on top and the two on the bottom are kind of what really allow us to bring maintenance. Okay, so the documentation assessment. So just from reading over different maintenance plans and understanding maintenance, these are kind of the big bullet points that often get thrown into an assessment. So instead of that tolerated well or without adverse reaction, these are kind of the maintenance kind of catch-all phrases. So what really needs to happen before all this is you need to really make sure that you're documenting their prior level of function really well, so that we can understand why maintenance is needed. So why we're maintaining this prior level of function. So why we're maintaining the function that we're at now, why we don't really want it to go worse or get different. And then you really need to focus on if they're falling at home. So you need to actually describe those falls. And then you need to also all those environmental factors and their personal factors. The one thing I want to point out on this slide is this last bullet point, that often we don't know why a patient would qualify for maintenance or if they would. But I can say this point always stays true. Almost every one of our patients fluctuates weekly. And we can say they fluctuate based on their fatigue, based on their sleep, based on their blood pressure, skin issues, or intermittent pain. So right there alone, you're describing the fact as to why they need therapy, because they're fluctuating weekly. So every week, technically something in their plan probably needs to change, or their treatment probably needs adjusted for that day. So that's kind of a nice one to use. So frequency and dosage. So I know that frequency and dosage is a high question. So again, there's no rule of thumb. So there's no way I can tell you if they have this diagnosis, it's 2 times a week. If they have this diagnosis, it's 1 time a week. But what I can say is it's up to the therapist. You can see a patient multiple times a week. You can see them once a month. You can see them once every 3 months. But what we need to look at to determine this is their deterioration risk, their goals, their abilities, their tolerance to therapy, and then also using our evidence-based practice. Okay, so what is a deterioration risk? So this is kind of a 1, 2, 3. We ask these questions to kind of figure out what a deterioration risk would be. So how fast are these people going to change without us? So the first one is how quickly would they deteriorate without a maintenance program? The second one would be what are the impacts of this deterioration? What are they going to lose? Activity-wise, what are they going to lose participation-wise? And then the last one is what does the evidence say about frequency and dosage? So like I said before, when we're dealing with patients that have these changing medical conditions, in which a lot of our patients are a lot more sensitive because they already have brain injury. So generally, they're going to be changing. They're the ones that are going to be taking new medications when they come out. I mean, a lot of our MS patients at my clinic are changing medications as a new one comes out, or they're stopping medications, or they're trying a different blood pressure medication. So all these things kind of filter into what I'm going to do with them that day. Are they more tired that day? Okay, well, we're not going to push them to be walking 3,000 feet around the gym all day. So these are all things that I take into consideration when I treat. I take into the fact that how quickly would I expect them to deteriorate. So often I can see people deteriorate even sometimes as quickly as the week between the treatment. If I'm only seeing them once a week and the next week they're like, yeah, you know, my MS just different today. So I would say deterioration risk is definitely high on our priority list to try to understand. And then also just what are the impacts of them deteriorating? You know, what would happen to them? Would they actually be doing what they're doing now if they started to deteriorate? And then just again, how fast do you really think they would deteriorate? So with that in mind, I always say discharge with a plan. So reasons we would discharge or reasons we would consider discharging. Do they need to leave outpatient? Do they need home health? So are they becoming to a point where outpatient is too hard to get to, or they're really having issues getting out of their house at this point? At that point, we could see if we could transition them to home health. Home health is also another place that is allowed to do maintenance program. So if you're doing a maintenance program here, you can actually take your maintenance program and give it to the home health agency, and they should be able to continue it in the home health. Also, perhaps now they're more qualified for skilled nursing or inpatient rehab. So I know that we've had a few people who were on a maintenance plan with dementia or with Alzheimer's, and we have transitioned them to a skilled nursing facility. And skilled nursing also can do maintenance therapy. So if you are recommending them being discharged and they're going to either of these places, I highly recommend you send your maintenance plan with them, because that patient most likely will not get the maintenance therapy they need in those settings unless it's coming from you. And then also, have you talked to the family, and are they confident in their ability to handle all the home exercise program needs? And then lastly, if we are discharging them, we're often training these people in our setups, with our optimal setups, so with our tables, with our lots of people around to help if something does go wrong. And we're generally treating their range of motion exercises at a height that is comfortable to us. So I urge you to make sure that the family is comfortable with these exercise programs at their house. So what is the difference of doing the exercise program on a semi-hard mat versus a super padded bed that they're in? Or they have a bed that goes up and down, and now they're trying to do the range of motion while reaching over. Or now the patient is toileting on a bedside commode, and they know how to do that here, but when they get home, bedside commodes on the other side. So I really urge, before you continue to think about discharge, you're really thinking about the environment that they're going home to, not only who they're going home to, but what they're going home to. So making sure that if we are sending them home to do range of motion, that we understand that where they're gonna be doing it, what they're gonna be doing it in, and even to consider the time of day, because a lot of our patients, their tone fluctuates throughout the day with their medication. So even understanding, okay, we've always performed these exercises in the morning, and we can do them pretty easy, and we have them down to like a 15-minute set. But when we send them home, what if the caregiver is doing them at 10 o'clock at night? And now they have more tone, and now we're asking the caregiver to try to please break this tone the same way we were breaking it at 9 a.m. whenever we could just move back and forth. So really, when you go to discharge these patients, the plan you're setting up is almost always going to end up with some type of skill involved. So just, you really need to consider every single thing you're asking a caregiver to do. So research. So there is research now on Medicare maintenance therapy. Most of it is newer because Centers for Medicare Services have now just rewritten their policies and are now doing their educational campaigns. So most of it is from 2015, 16, and 17. But I will say the CDC and the World Health Organization all support maintenance therapy. The biggest thing that I can say is children has been a lot of focus with maintenance therapy and the topic of what to do with children. So what they've come down to is basically that transitioning through life as a child is kind of considered an ongoing changing condition, and that's really where maintenance therapy comes into play for children. So as these children grow, as they get more mobility, or even if they're staying the same, but as their bodies are getting bigger, are we continuously changing what we're doing? Are we changing our plans? Are we trying to meet the needs of this child? And what they've actually found out is that kids that generally stay in therapy, often it makes a huge difference between graduating high school and kind of moving out or staying at home and being a dependent. Because we're talking about kids that we're trying to teach immediately how to roll, how to sit up, how to move in a wheelchair, how to, even be out in society, as opposed to a lot of kids that are just getting home health for their lives, or they're maybe just going to inpatient stays periodically. Those are the kids that they found have actually had declines in function, and especially with the transition between leaving high school and then becoming an adult, those are the kids that are also having a lot of problems and not really figuring out where to put those people, because they no longer fit in the education system, so they're no longer getting services at school, and now they're considered an adult, and they have to figure out what to do with them. So they found that maintenance therapy has actually filled a huge gap there. And then also, it's been proven that after a year, most people lose almost everything they've gained from that hemi side in a stroke. But it was also proven that when patients continued with therapy, they were actually able to regain that. So even after a year later, they were still able to regain what they had originally gained. And then importance to our population. So just specifically to the people we generally see here. And I know our populations are a little bit different between the two clinics, but it really is a benefit to almost all of our neurological patients, because we're in a field that is constantly changing, and I will say it's definitely still an art. So there's new treatments out there kind of all the time. There's new medications out there, and there's always new equipment and new toys to play with. So I will say it's at a time where it's up to us to provide this to our patients, to kind of show our patients the way that there is something out there for them. They don't need to just sit at home. I will also say that we are also the best advocates in the medical community, again, because we do spend so much time with everybody. And we're also the ones that really understand their needs, because we're generally some of the only people that take into consideration their whole family, take into consideration their whole person. So I will say, I think maintenance therapy really forces you as a therapist to really evaluate how you're treating, because it really made me rethink every single cue I give to patients. Am I actually being skilled, or am I kind of just sitting there hanging out? It's made me look into different type of treatment styles. So we've gone as far as using lights. We've gone as far as doing dark therapy, putting people in dark rooms, seeing if they'll even move their head to just lights. We've done as far as putting people in different environments. I've taken them outside just to see what gets them to respond, because not everyone's going to respond to the same thing. So I will say it's definitely made me a better therapist trying to find ways to get these people involved. And I will say that every single person that I've used it with, it's definitely been a benefit too. So I was going to run through an example really quick. So basically, I will just tell you synopsis about her. It was a woman. She had MS, so she had relapsing remitting MS. She has diabetes and hypertension. She came to us asking us for therapy. Her primary mode of mobility was with a wheelchair or a scooter, so she wasn't really walking at the time. And basically, she was just very open to therapy. So we initial eval'd her, and we saw her 2 times a week. So after about 12 weeks, so 24 visits, we saw improvements in her sitting balance, we saw improvements in her standing tolerance, and we saw her improvements in her ability to stand with one upper extremity, which opened up a whole world for her because now she could do ADLs and IADLs. So we saw her for 5 more weeks, and then at that time we saw she was kind of slowing in this progress level. So at that point, I asked, should she transition to maintenance? So these are kind of the questions that I go through in my head when I'm asking myself, should she transition to maintenance? So has the patient reached her maximal ability? At this point, it seems like it, because we've had her for 5 more sessions, 5 more weeks, so 10 more sessions. The last 5, everything's kind of been the same. The last 2 progress notes were pretty much the same. So I'd say yes, right now, for now, it's the maximum potential. Does she need a dynamic plan of care based on a chronic or a progressive nature of her disease? And yes. And then why? Because daily modifications, we're changing her plan every single day based on her fatigue and her changing status. And then yes, she had relapsing remitting MS. Does she have a highly motivated family? So yes, she did. So she has a highly motivated family. So maybe they could perform it at home. So then we go down. Can they perform it at home? And no. Her husband actually had undergone multiple back surgeries, and he actually was no longer allowed to lift or bend over. So any of the skills we were asking him to do would be unsafe. So standing at home, if she was to happen to lose her balance and he was to grab her at an instant, there is a chance he could injure his back again. So skilled balance and strength program needed to maintain the goals. So did she need this balance and strength program? Yeah, she did. And due to her dependent nature and needing equipment, that's also why we did it. We can transitioned her to maintenance because she also was using equipment in the clinic that wasn't available to her at home. We used the tram often to challenge her limits of stability and to get her to feel confident enough to stand with one hand. And then skilled knowledge needed to monitor vitals. That's another reason why someone would be in maintenance. And so yes, because she had diabetes and hypertension. So often we would have her check her sugar levels when we would push her or whenever we would notice something was different. And then the last question, which generally is always yes, but there are some cases, is daily activity a high priority? And with her, it obviously was, because she could get contractures or skin breakdown pretty easily because she spent most of her day in a wheelchair. So we definitely transitioned her to maintenance. And I will say we performed a re-exam. So we made new goals with our emphasis on maintenance. Her doctor agreed to it. And then at that time, we had her in maintenance therapy for 1 time a week. And then while she was in maintenance therapy, we noticed that her fine motor skills started to decline. So we actually recommended her for OT, and she was seen on a rehabilitative program for OT. And then after, I can tell you now because we still have her, she still is being seen by OT and PT, and OT has now transitioned her to a maintenance program. We see her for PT once a week, and then for OT they see her 3 times a month, so 3 weeks out of the month with the last month of the week off. So that's what OT has decided they believe works for her, and it seems to be working. And I will say she's actually done great, and she's kept everything she's had, and she actually is no longer on MS medications because she felt like they weren't helping her. So she actually went off of the MS medications and has kept every single gain that she's had. So I will say she's one of our patients that I think definitely has benefited a lot from maintenance therapy. Okay, so I know that was a lot to take in. I think maintenance is definitely its own beast. I mean, it's definitely something different than anything we consider regular therapy. So I know that it's hard to wrap around and it takes a long time to understand. So what I want to say is I'm going to ask for questions now, but I know there's probably going to be more questions after you think about it, and I also know it's the middle of the day and you have patients coming in. So please write me emails, call us, let me know your questions that you think of, or if you even have a patient scenario you wanted to work through or ask specific questions about, I'm more than happy to try to help you kind of work through these questions about patients or about particular plans. And then also I think it just takes time, and it really, for me, it took one patient very much declining within 6 months to realize how important it was. So sometimes I will say we start people out on maintenance plans, and sometimes we then transition to 1 time a month. And if it's working, then we let it go. But if we start to see that decline, we bump it back up to 1 to 2 times a week, or even just 2 times a month. So maintenance is kind of fluid in that way. You are allowed to go between stages of it. So if you know that they are getting a new piece of equipment and you're only seeing them 1 time a week, maybe that's the time you up it to 2 times a week. But like I said, I will ask questions. Anybody have questions now? And then if you have anything else that we didn't hit, let me know.